which can certainly disrupt their everything really in their body, their electrolyte balance, which can throw you into an arrhythmia. Other medical conditions like diabetes, COPD, congestive heart failure, all can cause problems. Sepsis, which is overall infection to a severe point. Your diet can lead to cardiac problems. A poor diet throughout your whole life, if you don't drink enough water, all you drink is soda, eventually you're probably going to have some complications from it. Obesity, obviously. Excuse me. Obesity, if you're overweight, that puts more strain on your body, puts more strain on your heart, you're going to have some cardiac problems. Drugs or alcohol. If you're a frequent substance abuser, as in you use cocaine, methamphetamine, any stimulants really, makes your heart work harder, which can lead to some problems. You hear every now and then about a person who uses cocaine that ends up having a STEMI, just because their heart's beating so fast through the clot. So obtaining a medical, we're going to go into histories and assessments. All right. So obtaining a medical history, especially with a cardiac patient, is vital to their proper treatment and a full assessment. Especially these cardiac patients, you need to know who's their cardiologist, what kind of medical problems do they have. Have they ever had any stents, because that can show on the 12 lead? Do they have any prior caths at all? Were they clean cath? Was it normal? Do they have this chest pain often? Are they prescribed nitroglycerin? Because if so, that could probably lead you to the fact that they do have chest pain often. So this is something they experience. Do they have, or what kind of medications, other medications do they take, which can also lead to the other cardiac problems? Are they compliant with their medications? You'll find that a lot of people either simply just choose not to take them, they can't afford them, or they just don't know how to take them, which can lead to further issues. So just obtain a full medical history to the absolute best of your ability. Then you need to also always do a full set of vitals, hands-on visual assessment, especially two people team, which should be any ambulance really, is when providers get the baseline vital, when provider get the 12 lead, especially in cardiac emergency, it's going to get that done quick. Putting your hands on the patient is extremely important. You can feel if they're cool, clammy, diaphoretic, all that jazz. Then they also need to assess their pulse. You can either do it carotid, radial, any site you can find. Does it feel normal? Is it bounding? Is it thready? Does it feel like it's in a regular rhythm? Does it feel irregular? Is there any breathing abnormalities? Does this patient feel or look like they're having some shortness of breath, but they're just not admitting it to you? So that can also indicate some other things going on. So this is just a mnemonic that was taught to me in my basic class, and I've used throughout into my paramedic career and everything. So it's OPQRST. I'm sure a lot of you will probably taught this as well. So the O stands for onset. When did the pain begin? Did it begin 2 hours ago, 2 days ago, 30 minutes ago? Important to find out. So provocation. What makes the pain better or worse? If you cough, does that make the pain worse? Does anything really make the pain worse or better? Have you taken medication? Does that make it worse or better? Quality. Can you describe the pain? Does the pain feel like it's an actual pressure, like with an elephant sitting in your chest? Is it actually abdominal pain? How bad is it? Is it like a severe, sharp pain, or is it just a dull pain? Radiation. Does the pain stay in one area or move? So like I was saying earlier with the classic chest pain you see everywhere on the TV or anything, patient has a chest pain, they grab their chest, they always say their pain's moving to the arm or their jaw, something's numb. But chest pain can also radiate into that, and there's other medical conditions like if you have a gallbladder problem, a lot of time that pain can radiate from your stomach into your chest and into your back. So it's just important to know those few things too. And time. How long has this pain been going on? Again, it kind of goes on with the onset, but how long has it been going on? Have you had this pain before? Has it been going on for 2 weeks? Just important questions to know. So now we're only talking about some first-line medications. So first-line medications are considered medications that can be used at home by the patient prior to seeking medical treatment, call 911, or some of the first medications that we use on an ambulance when we determine that they're experiencing a cardiac emergency. So aspirin and nitroglycerin are the main two. A lot of people with a cardiac history already have these medications at home. It's important to know that they may not know how to take them. They may not know what kind of symptoms to look for and when they shouldn't take them. So we're going to talk about aspirin. Aspirin is an oral NSAID. It should be chewed in a cardiac emergency. It is sold over the counter, but it can also be used for pain or inflammation. So it acts in a way that thins the blood. I know people hate when that's said, but for our purposes, it does thin blood, or platelet aggregation, and it helps prevent blood clots. So it is used as both a preventative and a treatment. People are normally instructed to take an aspirin every day, especially if they have a cardiac history. But if they're also having a current cardiac emergency, it should be given. So a study showed by the American Heart Association showed a 50 to 70% decrease in mortality during the acute phase of an MI, meaning when they were actively identified of having a STEMI or some type of infarction. And then a 50 to 60% decrease in mortality over 3 months after the infarction to 3 years while taking aspirin. So it does have some complications. It can increase bleeding, obviously, because it acts as a blood thinner. A lot of these people have like GI bleeds or ulcers or just abnormal bleeding throughout. So in our agency, we give 324 milligrams and it has to be chewed. So nitroglycerin, that is a prescription medication. It can be either given orally or by spray. Some at home, I've only seen people have it orally, but at another agency I work for, we do have it via spray. So the normal dose is, starting dose is 0.4, and for our protocol, we can only give it 3 times. So it can help relieve the chest pain, and also helps treat the infarction. So it's a vasodilator, meaning that it acts in a way that dilates the blood vessels. So it helps assist the heart in this case to receive oxygen-rich blood if a vessel is partially occluded or constricted. So you always need to use this with caution, because like I said, going back to some patients do not know how to use it properly. They don't know that if your blood pressure starts to get low, you should not take it, because it can drop your blood pressure pretty substantially for some people. In our agency, and in my personal experience, I don't give it for anybody that has a systolic blood pressure over 100 or getting close to it. And me personally, if their blood pressure is not super high, I always like to have an IV beforehand, just because some people it barely touches their blood pressure, and some people it drops it substantially. And then you can always give them fluid to fix that if you have an IV. And then erectile dysfunction medications, you shouldn't be giving nitro if they've taken an erectile dysfunction medication within the last 24 hours. So we're going to touch on 3 leads and 12 leads. So this is a tool used by medical professionals in the pre-hospital and hospital setting to help treat and diagnose cardiac conditions. So 3 leads is a basic rhythm strip that can help determine any abnormalities with rate or regularity. It is placed on the limbs. They are called limb leads. They are not placed on the abdomen or the chest. They are limb leads. The only time that they should be placed on the abdomen is if your patient doesn't have legs or doesn't have arms, or if they have a condition where they have severe tremors in their extremities. Otherwise, limb leads. Sorry. So 12 leads. They are also a diagnostic tool that is essential for cardiac emergencies. They provide a full picture of the heart, showing 12 different electrical positions. They are essential for diagnosing myocardial infarctions, cardiac arrhythmias, or patient monitoring short-term or long-term. So like I said, this is a 3-lead placement. Extremities. I don't know, ignore this one. Extremities. Alright, this is a 12-lead placement. So typically they go V1, V2 on the chest wall, and then V2, V3, V4, V5, V6, which is going to go under your left breast. So we're going to move on to treatments now. Stand by. So treatments will vary patient by patient. In the pre-hospital setting, treatment is determined by the severity of the condition a lot of times. Sometimes it's better just sit on your hands in some cases, but a lot of times we do have the tools and medications to treat these people. So treatments can vary from simple monitoring, fluid boluses medications, or to electrical therapy. It is important to monitor the patient's condition throughout transport and treatment, as their condition can change quickly. Especially if you give them a medication, especially if they've had chest pain, you need serial 12 leads, vitals reassessed every 5 to 10 minutes. Going back to EKG should be monitored throughout patient contact until patient care is successfully transferred. And always take into consideration the patient's prior medical history and medications, because some medications we give can interact with some of the patient medications that they've already taken. So let's go over treatments per condition. Today we're going to talk about angina, stable and unstable. So treatment in the pre-hospital setting can include just simple monitoring, including serial and 12-lead EKGs, because especially in stable angina, could lead to something worse. Aspirin, nitroglycerin if the blood pressure allows and they haven't taken any ED medication. Repeat set of vitals, and pain medication if their pain is not being cleared by the nitroglycerin or the aspirin. Sinus tachycardia. So treatment for this rhythm is normally determined by the underlying rate and cause. So if a patient's sitting at like 108 and they have no other abnormalities and symptoms, then you're probably okay just to do a basic monitoring. So if the patient is symptomatic or they have a heart rate about 130 and there's other indications like a fever or orthostatic vital signs, which is just when the patient goes from a sitting position to a standing position or laying down to a standing position, and their blood pressure drops significantly. That normally is a good indication that there's probably some fluid imbalance in there. So that would be an indication for fluid therapy. If they have a fever, fluid therapy can help lower that temperature. Tylenol can help with that too. Cooling measures if they also have a high enough fever. If the tachycardia is caused by anxiety, then just calming measures if needed, to the extent where you think you should be at, either just talking to the patient, calming them down. If you have to get to a sedative, that's a whole different thing. Bradycardia, I'll keep saying this, it also is determined by your symptoms. May include fluid therapy. Dehydration is known to cause bradycardia. You can be treated with medications such as atropine, dopamine, and epinephrine. So pacing, that's when your patient's extremely symptomatic. Either they're altered, they have extreme cardiac compromise, they are extremely hypotensive, nothing's making it better. That's when you would go to a pacing. Pacing is just a procedure that you would place your Kindle pads on, and it uses electrical impulses to stimulate the heart, so their heart will beat faster, and hopefully try and stabilize them until they can get to the hospital. So if a patient, like I said, is using severe symptoms or if the patient begins to deteriorate. And I'll say it again, always look for an underlying cause. Did they take too much of their medication? Are they on too many types of beta blockers or other medications that can slow their heart rate? Are they super dehydrated? Important things to know for treating your patient. Blood pressure abnormalities, hypertension. So in the pre-hospital setting, in my agency, our treatment for hypertension is kind of limited. It's normally just to monitor your baseline vitals and EKGs. Perform a neuro exam, because especially if their blood pressure is super high, because like I said earlier, hypertension can increase your risk of strokes. Full medical history. Do they have prior blood pressure problems? Do they take a medication for it? A lot of people, when they ask, hey, do you have high blood pressure, they're like, well, it's treated by medication, so I don't have it anymore. They still have it, it's just treated by medication. Underlying cause. Pain. Do they have pain, or is something hurting really bad? Are they anxious about something that can shoot their blood pressure up too? And then just transport, monitor, treat any other symptoms that arise during transport. Hypotension. So treatment can include their fluid therapy, either normal saline or LR, determines by what you think they need. If their condition does not respond to fluid, in my agency we had available dopamine, Levophed, or epinephrine. So again, underlying cause should be considered. It can be caused by dehydration, medications, trauma, internal bleeding, or other cardiac conditions, or sepsis. So treatment should include quick recognition. Let's get this slide. So this is treatment for a STEMI or a myocardial infarction. Treatment should be quick, include quick recognition and cath lab activation. We have a cath lab determining where you are in my county, approximately about 30 to 45 minutes away. As soon as you recognize that patient's having an infarction, you should contact the receiving hospital, let them know so they can get ready. While en route to the hospital, they should be given aspirin if they were not instructed to give it or take it already. Nitroglycerin should be considered, but going back to the different types of MIs, especially with an inferior MI, that can affect their blood pressure pretty substantially. So you need to monitor that blood pressure and be cautious with nitroglycerin. Fluid bolus is needed. Again, going back, it can cause hypotension. So oxygen. Oxygen is only needed in patients with an O2 sat of under 94%. So, sorry, I'm just written down. So, like I was saying before, there is no need to give that patient oxygen if they are under 94% because there is an actual study that showed that it is dangerous to patients that are having an MI or a non-STEMI, that the over-oxygenation of these patients can make it worse. Especially with supplemental oxygen, it can lead to larger MIs at 6 months down the line. But, and then going back, because this emergency can affect so many body systems, treatment may include multiple medications or treatments to manage